believe Rosa would like to comment on Mr. Winsley's comments.
I just have to make a couple of corrections. First, with regard to the last thing, I think you should just, Mr. Winsley, just take a look at where Connecticut is going. Connecticut is in the process. There's a group that's been set up to talk about setting up the exchange in the state of Connecticut. We are moving forward on an exchange. The exchange is a place, in fact, where you deal with private insurance and competition in the system. This is not federally run. Most states are putting forward an exchange. Quite frankly, a number of states have held back, waiting to see what happens in the election on November 6th, which is a little bit irresponsible because whether or not there is an elections, people's health care is at risk. But so that you should really understand what the exchange is all about. Private health insurance, options, choices for people to make the determination what is in their best interest. For the first time, it puts some competition into the system. Second point you made, and I wouldn't have responded except this is the second time that you have made it, once on when we were on Channel 3 together, and that is about the PSA. As a matter of fact, in that instance, you literally accused me of killing African-American men, and I didn't respond at the time, but I take offense at that. And I'd also say first and foremost that there are 40 members of the Congressional Black Caucus in the United States House of Representatives. All of them voted for the Affordable Care Act. I think that that they would have an issue with what you're saying. Let me just talk about the tests. I mentioned to you a moment ago, Science Board went through preventive care. And they said, these are the services that are proven effective. They said inconclusive was the PSA for prostate cancer, and inconclusive, by the way, was the CA-125, which is the blood test for ovarian cancer. I'm a 26-year survivor of ovarian cancer. So I wouldn't do anything to harm people's opportunity to be able to survive. They said inconclusive. What it means is your insurance could cover this test. They could even say they won't charge you for it. But on the list of services where there is not a copay, it is not listed. Based on science, not on a whim, or not on anyone's political party or political philosophy.
I think I'd like to have both candidates address the affordability of the Affordable Care Act. It seems that many people expected that the cost of health insurance would come down. And so far, that doesn't seem to be the case. Both of you take a few seconds to address the affordability, and can we afford the Affordable Care Act?
The short answer is no. It's like trying to make everyone in America rich. It's impossible. You can make everyone in America equally poor or mediocre. The only way for the government to actually provide the health care in the way it's structured in the Affordable Care Act is by regulating the services that they provide. Because again, everything has to be looked at based on how much it costs. Our deficit right now is what? $16 trillion? The Congresswoman would actually know better than me what the exact number is. But the short answer is no. You have to have some way of rationing, distributing, or regulating care based on cost, which is, again, why I would look for more private sector solutions. One simple one, you should be able to shop for your health insurance across state lines, much the same way you buy car insurance. Why can't small employers pool together and purchase health insurance at lower rates in order to cover more people, the same way larger corporations do? And that's just a couple of things that we could look at. Again, healthcare, it is a good idea, I just think that the ACA is a good idea done badly. So, is it affordable long-term? No, it's not.
Rosa, would you like to address the affordability of the Affordable Care Act?
Thank you. So that you do know, when the exchanges are implemented, yes, indeed, people can purchase their insurance across state lines. And just to be clear about that, because, you know, we passed the bill in 2010, and all kinds of people asked me whether I read the bill. I read it, I reread it, read it again, etc., because of the import of it. If I could, because I asked the question, if I grab my BlackBerry, I can give you the exact answer, but I will just tell you that, in fact, when the exchanges are implemented, there will be the ability. We did that right at the last moment of the, when we were trying to pass the piece of legislation. Also, at that juncture, with the with out-of-state companies, if Connecticut approves, they can participate in the exchange as well. So that is the Connecticut piece of this. The affordability. We said that it was about bringing the cost of health care down, bending that cost curve so that people could get health insurance. And there were a number of ways in which one could move to implement those efforts. Several pieces are in place, several are not. The exchanges are not in place until 2014. That is the place, as I mentioned a moment ago, where you will have a competition in the system that says people will shop for their health care in a way that they, as small businesses, will do the same. Also, insurance companies will not be able to just raise their premiums willy-nilly. There will be a state review board that will examine the rationale for an increase and make a determination. You have to prove why you need it. But the point of saying that you have a choice. This is the price, it meets my needs. I'm going to look over here to see what they have. Does it meet my needs by price, by coverage, etc., which will, of its nature, look at how you can drive down costs. Second, we have over 30 million people today who do not have health insurance coverage. If we move in the direction that the Affordable Care wants to take us to insure that number of people, it's in bulk. You go to Costco and you get a big jar of mayonnaise. You don't get 12 little ones at the local store. The cost goes down in bulk by insuring others. Attached to that, uncompensated care. Those who do not now have health insurance get health care services covered. They go to an emergency. If they are covered and are co-paying, the cost comes down. The cost to hospitals comes down. Already in the state of Connecticut, you've got a number of physicians groups who are coming together around this notion of the of accountable care, where every person who's dealing with an individual's care is plugged into a system, so there's less duplication, there's a whole variety of other things, again, with the thought of driving the cost down. We're looking at, again, with regard to looking at the waste and actually the fraud and abuse in the system of driving the costs down. Overpayments to insurance companies, to pharmaceutical companies are being addressed in the Affordable Care Act. The issue is, how do you bend that cost curve? How do you start to bring costs down? The program is not even implemented in full today. It is really, quite frankly, too early to make a judgment as to whether or not. But there are mechanisms in place which, if we use them, and monitor them and are vigilant about them have the ability to drive the cost down. The one that I know more, not know most about, but it's the articles in the paper are saying that in terms of young people being on their parents' health insurance has driven the numbers of uninsured down as well as costs down for those families. You know, it took us 100 years to pass a piece of legislation that addressed this serious, serious health delivery system that we have. You want to talk about rationing care? Care is being rationed today to people who have the coverage who don't have the coverage. That's why we passed this legislation and worked hard to do it. It has to be implemented in full, and we have to be vigilant about it and monitor it and be serious about its implementation so that we drive down that cost curve.